Welcome back, dental students, to Master Oral Pathology. Today, we're diving into a bacterial infection that is just absolutely devastating. It literally destroys the face. We're talking about Noma. This is one condition you absolutely must be ready to recognize. Not just because it's high yield for your board exams, but because understanding how it works really unlocks a much deeper comprehension of how systemic health dictates oral mucosal immunity. We're going to explore how a seemingly minor oral ulcer can rapidly spiral into a life-threatening, tissue-destroying crisis when the body's defenses just collapse.
Here's our clinical roadmap for today. We'll quickly cover understanding Noma, its etiology and pathogenesis, the clinical features, and finally, wrap up with the histopathology and diagnosis. Let's get right into it.
Section 1. Understanding Noma. Let's take a look at the baseline definitions.
So you'll rarely see Noma in developed nations today, but it remains a major and frankly tragic cause of childhood morbidity and mortality in parts of Africa, South America, and Asia. You'll often see it popping up in the medical literature under the names Cancrum Oris or gangrenous stomatitis. At its core, this is a highly destructive, rapidly progressing gangrenous process of the orificial tissues. But the absolute key takeaway for your foundational knowledge here isn't just what it does, it's who it targets. This is primarily a disease of malnourished children. When severe malnutrition starves the body of essential nutrients, the immune system basically hits a wall and fails. That massive systemic vulnerability paves the way for intense, unchecked, localized oral destruction. And this demographic divide becomes even clearer when we look at its variants. While the classic presentation of Noma hits older children in developing regions, we also see a highly specific variant in severely compromised newborns. This is known as Noma neonaturarum. Why target these specific infants? Well, low birth weight infants suffering from other debilitating diseases have immune systems that haven't even had a chance to develop yet, let alone fight off a massive systemic challenge. But across both the classic and neonatal presentations, the underlying clinical theme is exactly the same. You're dealing with a host whose physiological defenses are either entirely absent or just drastically lowered. Moving on to Section 2, Etiology and Pathogenesis. Let's see how these compromised defenses actually lead to such rapid destruction. Okay, so before the destructive bacteria can even take hold, the host's defenses have to be severely weakened by a perfect storm of clinical vulnerabilities. First, on a systemic disease level, we're looking at concurrent severe illnesses, things like pneumonia or sepsis that are already draining the body's resources. Then, locally, right within the oral cavity, pre-existing conditions provide the initial gateway. A simple case of acute necrotizing gingivitis, a bit of minor physical trauma, or even routine mucosal ulcers can suddenly become a massive systemic breach. Add severe malnutrition or other debilitating conditions into the mix, and you have literally stripped away every single natural immune barrier the body possesses.
Now, the massive tissue necrosis doesn't just happen out of nowhere. It is a direct consequence of an invasion by opportunistic anaerobic bacteria. And the key word there is opportunistic. These bacteria are often already present, just hanging out, waiting in the wings. Without that severely compromised host we just talked about, these microorganisms simply wouldn't be able to mount such a devastating and rapid attack on the facial tissues. They exploit the broken armor, turning a vulnerable state into a total catastrophic infection.
For your exams, you definitely need to know the specific opportunistic pathogens involved here. But don't just memorize a list. Try to understand how they work together as a deadly microbial consortium. The absolute ringleader of this group is a heavy infestation of Fusobacterium necrophorum. It leads the charge, but it absolutely doesn't work alone. It brings along some opportunistic accomplices: Prevotella intermedia, Borrelia vincenti, Treponema denticola, Porphyromonas gingivalis, and Staphylococcus aureus. This specific alliance of microorganisms capitalizes on those completely depleted oral defenses. They join forces to turn what might have started as just a benign gingival ulcer into a massive, rapidly spreading gangrenous infection.
All right, Section 3, Clinical Features. Let's walk through this rapid progression.
This sequence outlines the terrifyingly rapid clinical progression of the disease. It almost always kicks off as a painful ulceration, usually right on the gingiva or the buccal mucosa, but it does not stay localized for long. From there, the spread is incredibly aggressive, resulting rapidly in severe soft tissue necrosis. The tissue literally dies and sloughs away. This exposes or denudes the underlying bone, which eventually leads to bone necrosis and sequestration. And because the supporting periodontal attachment is completely destroyed by all this spreading necrosis, the teeth in the affected area become loose and just simply exfoliate. Ultimately, these aggressive organisms penetrate straight through the facial structures, the cheek, the lip, or the palate. It's a visually and clinically devastating progression, and it happens with shocking speed.
Finally, Section 4, histopathology and diagnosis. Let's take this into the lab and look at the microscopic diagnosis.
So clinically, we see this massive tissue destruction. But what is actually happening at the cellular level to confirm this necrosis? As future clinicians, bridging that gap between the macro and the micro is absolutely essential for your diagnostic skills. When we look closely at a biopsy of the affected epithelium, we see some intense inflammatory changes. First off, there is spongiosis, which, if you remember, is essentially severe intercellular swelling and edema, along with distinct vesiculation. Moving down into the immediate supporting connective tissue, there's a pronounced perivascular lymphocytocytic infiltrate. You'll also notice that the blood vessels in the area are typically heavily dilated, and you might even spot occasional eosinophils in the mix. You can kind of think of these dilated blood vessels as the body's desperate, failed attempt to rush immune cells and reinforcements to a losing battle. Ultimately, these microscopic hallmarks confirm the incredibly aggressive tissue-destroying nature of the infection. Now, the ultimate takeaway for both your board exams and your future clinical practice is this: you cannot rely on histopathology alone. You have to connect the clinical presentation back to the patient's compromised systemic history. A careful history taking to establish a cause and effect relationship is absolutely essential. The microscope only tells half the story. The patient's background tells the rest. Remember that perfect storm we mapped out earlier? The severe systemic disease, the preceding local oral infection, the profound malnutrition? Your diagnostic process requires taking a meticulous patient history to uncover those exact underlying vulnerabilities. And because you're relying so heavily on that clinical history, you've got to be really careful with your testing methods. The pathology literature makes it very clear that patch testing the oral mucosa in these specific cases is incredibly difficult, but more importantly, it is highly prone to dangerous false negative results that could lead you completely astray in your treatment plan. Sure, biopsy findings will confirm the inflammatory and necrotic cellular changes, but your primary, most accurate diagnostic tool is synthesizing that clinical presentation with the actual physiological reality of the patient sitting right in front of you.
Ultimately, Noma represents the devastating intersection of systemic vulnerability and aggressive oral bacteria. It shows us, in perhaps the most extreme way possible, that a localized oral lesion is so often a window into the patient's entire physiological state. So as we wrap up this breakdown on master oral pathology, I want to leave you with this question to ponder as you head into your clinical practice. What is that simple mucosal ulcer actually trying to tell you about your patient's overall systemic health?